Able
Is
to,
it?
yes, sir. We are able to see, sir.
Okay, thank you. Thank you. Now, this is a story of a 34-year-old employee in electricity board. He was found unconscious in the quarters where he was staying alone near his office 2 days back. He used to take alcohol regularly. He was brought to our hospital and regained consciousness and found to be speaking relevantly. But his behavior to the relatives and doctors were perfectly normal, keeping good social manners. So his problem is irrelevant talk following a loss of consciousness. And in fact, he was found unconscious in his room, staying alone. Now, this is the story in Malayalam, but I'll convert it into English later on. But listen to his story. I'm asking where he is. He said he's in Kovur, that is far away from Trivandrum. What about you? He's perfectly fine. Yes, no problem. I asked you why the Prime Minister, he said correctly. As a Chief Minister.
Chief Minister. Today's Chief Minister. Today's Chief Minister is six months point in the life of.
He said he didn't remember because every 6 months Chief Minister is changing.
No, sir, in the afternoon only I came. Only afternoon.
Oh, sir, he came only in the afternoon.
Yesterday I was in Kerala.
He said yesterday he was in Kerala.
Around 6 o'clock only I have reached.
He came here only at 6 o'clock. In fact, came 2 days back.
There was some travel and other things. Have you seen me before? Yes, sir.
Last time, have you seen me before?
6 years, but not much discussion. Okay. Just have some. Last when
did you see me last?
On that in your premises.
See me years back in my premises. Okay, I will convert it. He is fully conscious. He greets normally, responds to questions without any delay. Now, this is the question I asked and the answer. Where are you now? I'm in Kovur, a place about 250 kilometers away. But actually, we is in Nargovil, we're staying in Nargovil, but it's admitted in Trivandrum. And how are you doing? Fine, no problem. Are you perfectly fine? Yes, perfectly fine. What is the name of our Prime Minister? He said correctly, Narendra Modi. What is the name of Chief Minister? He thought for some time and told that he could not recollect since Chief Minister changes every 6 months. Did someone come to see you yesterday? No. He said he came here only this afternoon. In fact, he has been there for 2 days. Yesterday he was in Kerala. Now landed in this place only a few hours back. When did you see me last? 6 years back. Where did you see me? In your premises. So this is the question I asked. This is the answers he given me. So what is his problem?
Confabulation, sir.
Very good. Perfect. He has got an impairment of recent memory and is confabulating. Many things is confabulating. Okay. With confabulation. Very good. Now, what is the likely diagnosis in this patient? Okay, I'll show the next video also. This is the next part of the video. It's got a asymmetric nystagmus, upward no nystagmus. You go to the right also, there is a possibly nystagmus to the right side. Power is normal. Yes, coordination of both upper limb.
Again nose, again feeling. The other hand. This hand.
I made him to stand up, but he fell down. Reflexes were normal. He used to take alcohol regularly. And he was made to stand up. That's a good manner. He just collapsed to the floor. He could not stand because of the ataxia.
Wernicke for support.
Okay, very good. Now let us see the MRI of the patient. This is a diffusion film. I think better seen and flare. This is a flare sequence. You can see the hyperintensity in the posterior part of the medulla, the periaqueductal area. The medial thalamus. I'll show that video once again. In fact, this hyperintensity in the posterior part of the medulla you can make out in the periventricular region. Then in the periaqueductal area and in the hypothalamus, dorsal medial nucleus of the thalamus, and this is the fornix. This is the coronal filling. Again, you can make out the hyperdensity adjoining the third ventricle, that middle thalamus, and in the periaqueduct area in the midbrain and near the fourth ventricle. This is the T2 weighted. Again, shows hyperdensity there in the periaqueduct area, hypothalamus. SW did not show any booming anywhere. Sometimes Wernicke can produce blooming due to hemorrhage in the medial thalamus, which was not there in this patient. And this is the T1 weighted. There is hyperintensity in the globus pallidus in T1 weighted. So this is the picture showing the hyperintensity posteriorly, periaqueduct area. Okay, so that's the story of the patient. So what is the diagnosis ultimately? Straightforward case, short case. Wernicke's encephalopathy. This is a classical MRI appearance of Wernickelopathy. The sign common is the mammillary body hyperintensity, which was not seen in this patient. Usually that is said to be the first thing to occur, but here it was not that much hyperintense, but all other areas are classically situated there. Is there anything else other than the Wernicke's encephalopathy in this patient?
Extrapontine myelinolysis possible, sir?
No, this extrapontine myelinosis usually it affects the basal ganglia here. Here affecting the dorsomedial nucleus of the thalamus, medial and hypothalamus, periaqueductal gray. That is a classical distribution of the Wernicke's encephalopathy. And what did this? You look at the MRI here. Anything else you find here? What is that thing? Hyperintensity in the globus pallidus indicate? That one.
Toxin, sir.
Pardon?
Toxin.
Hyperintensity. Yeah, that's typically seen in hepatic encephalopathy. In hepatic encephalopathy, you find hyperintensity in T1 weighted sequence in the globus pallidus. So it's in fact chronic alcoholism, hepatic encephalopathy, now presented with alcoholic binge, went into, he was not taking anything for 2-3 days, went into Wernicke's encephalopathy. Now, I bought this case mainly two things, the typical confabulation. If you know Malayalam, you would have understood very easily. And second point is that the classical MRI appearance, it should not mistake, is typical of Wernicke's encephalopathy. So any questions? These are the areas affected in Wernicke's encephalopathy. Periventricular regions of thalamus, especially medial thalamus, hypothalamus, mammillary bodies, periaqueductal region, floor of the fourth ventricle. Other areas that may be affected include cerebellum, cranial nucleus, and cerebral cortex. They are hyperintense in T2 with or without contrast enhancement. Okay, shall I go to the proper case? Any questions here in this case?
Is it completely reversible with time?
No, in fact, he did not. I mean, he was admitted for just 5 days. His memory impairment and the attacks did not improve. Still continuing to have, but little less now, but it's still persisting. What literature says that his ataxia may improve first, then the cognitive impairment. but it maybe take some time. Already started 5 days back.
He did not have any ophthalmoplegia, sir.
No ophthalmoplegia, because even nystagmus was there, no ophthalmoplegia. Usually they can have ophthalmoplegia like systemic palsy can occur, upbeat nystagmus can occur, Wernicke encephalopathy, but it was not there in this patient. Okay, shall I go to the next case?
Yes.
Okay, this is a long case. This is a story of a 70-year-old man who was perfectly all right 2 days prior to admission. That night at 3 a.m., he got up from bed, complaining of neck pain, and went to the central hall and was lying on the sofa. After some time, tried to get up from the sofa. He could not get up. He called his daughter, and she noticed that he could not move both his lower limbs. At that time, there was no upper limb complaints, and he could lift both his upper limbs. That is at the night when the daughter saw the patient. On the next day morning, he noticed he could not move both his upper limbs as well. So he had weakness of both the lower limb and subsequently both upper limbs as well. However, he could speak normally. So this is the story of the patient, no sensory complaint. So 2 days history, night he complained of neck pain and followed by weakness of both the lower limbs. Over hours, he developed weakness of upper limbs with no cranial nerve symptomatology and no sensory symptoms. So this is the video of the patient. His ocular movements, people normal. Ocular movements normal.
ഇടത്തോട്ട് താഴെ നോക്കിച്ച ഇവിടെ മുകളില് കണ്ണൊന്ന് മുറുക്കി അടയ്ക്കാവോ?
No facial weakness.
പല്ലി അടിച്ച ഈന്ന്. ശരി, ഇനി വാതിറക്കച്ച.
Tongue movements normal. Palate also normal.
ആന്ന് പറഞ്ഞ് ആ ശബ്ദം ഉണ്ടാക്കുക. ആ മതി മതി, വിട്ടോ വിട്ടോ.
Yes, some mild hoarseness, but the palate movement is normal.
ഒന്നൊരു വാതിറന്ന് ആ പറഞ്ഞ് ആ.
I'll show the palate movement once again. Normal palate.
അങ്ങോട്ട് തള്ളിക്ക്, അതിന് വലത്തോട്ട്, അങ്ങോട്ട് എടുത്തോട്ട് വലത്തോട്ട്. ശരി പറഞ്ഞു വെച്ചാ.
See the palate movement, normal palate.
ഒന്നിനെ പറഞ്ഞ് ആ മതി മതി.
Okay, then come to the rest of the examination.
കഴുത്ത് അങ്ങോട്ടും തള്ളി പിടിക്കാവോ? ഇടത്തോട്ട്
on one side.
പിടിച്ചോണ്ടിരിക്കണ വെച്ചാ അങ്ങോട്ട് പിടിച്ചോണ്ടിരിക്കുക, ഇടത്തോട്ട് തള്ളിക്കോണ്ടിരിക്കേ, ഇങ്ങോട്ട് തള്ളിക്കോണ്ടിരിക്കേ, വലത്തോട്ട് തള്ളിക്കൊണ്ടിരിക്കേ. ഈ വശത്തോട്ട്
left sternum should appear more weak than the right side.
വേന ഉണ്ടെങ്കിൽ പറയണേ.
വേനയുണ്ടോ? stiffness.
ഇല്ലല്ലോ, ഇപ്പൊ ഇല്ലല്ലോ.
Then tone hypotonia. Sorry, mild spasticity. The fingers are slightly spastic. Sorry, fingers are slightly spastic. That was spastic. The finger pressures is spastic. Pronators were not spastic. At gate 0 power of both upper and lower. The object is normal. Upper limb presses, biceps and supinator triceps all brisk bilaterally. Finger pressure is also brisk. Ajax were brisk bilaterally. Angle is normally excited. Plantar both upgoing. The sensory system.
കണ്ടുപിടിക്കാൻ വേണ്ടിയിട്ടാ ഞാനിങ്ങനെ കുത്തി വരുമ്പോഴേ
Pain is normal.
കൂടുന്നെങ്കിൽ പറയണേ.
There is no area of sensory level
ഇല്ല ഒരേപോലെയാണോ? ആണ്.
He said they are all equal, no
എവിടെയെങ്കിലും
difference.
വേദന കൂടുന്നെങ്കിൽ പറയണേ. ഒരേപോലെയാണോ? ഒരേപോലെയാണ്.
The abdominal bodies were absent.
ഇനി വേദന
And check
കൂടുന്നെങ്കിൽ
the
പറയണേ.
pain again on the trunk.
എല്ലാം ഒരേപോലെ ഒരേപോലെ
He said it's
ഇതൊക്കെ
all
ഒരേപോലെ
same.
ആണെന്ന് പറയണം. ആണല്ലോ, ഇതൊക്കെ അറിയാമല്ലോ അച്ഛനെ. അച്ഛൻ ഇപ്പൊ ഒരു
Take the
കണ്ണടിക്കുന്ന
vibration.
എർത്തടിക്കുന്ന
Able
പോലെ
to feel vibration.
ഉണ്ടോ? ഉണ്ട്. ഇപ്പൊ ഉണ്ടോ?
He said yes.
ഇപ്പൊ തീരെ ഇപ്പൊ ഉണ്ടോ? ഇപ്പോഴുണ്ടോ? ഉണ്ട്. ഇപ്പോഴോ? ഇപ്പോഴോ? ഇപ്പോഴേ ഉണ്ട്.
But
മടക്കി
joint
നോക്കിയോ?
sensors normal in the upper limb.
അറിഞ്ഞൂടെങ്കിൽ അറിഞ്ഞൂടാ. അറിഞ്ഞൂടാ. ശരി.
Sorry, it's
ഇപ്പോഴോ?
impaired.
അറിഞ്ഞൂടാ.
He
അറിഞ്ഞൂടാ.
did not just say wrong limb, upper
ഇതോ?
limb joints was absent.
മടക്കിയിരിക്കാണോ നൂർത്തിരിക്കാണോ? അറിഞ്ഞൂടാ അല്ലേ? ഇപ്പോഴോ? നൂത്തിരിക്കുന്നു. ഇപ്പോഴോ?
He made mistakes in the upper limb.
അറിഞ്ഞൂടാ. അറിയാവോ അറിയത്തില്ലേ? ഇല്ല. അവിടെ ഇപ്പോഴോ? ഇപ്പോഴോ?
He made mistakes again.
ഇപ്പോഴേ?
He could not. Okay. So, now on examination, cranial is all normal except for the lateral rotation of the neck. Extraocular movements, palatal movement were normal. He was put on right shoe when the ward sister noticed mild cough while swallowing. However, palatal movements were normal. Motor systems, spasticity of both upper limbs, mainly in the finger flexors. Weakness of neck flexion, weakness of lateral, they're already told. Grade 0 to 1 power of all muscles of both upper and lower limb. DTR brisk, DTR in both upper limbs and lower limbs, except for both finger flexion reflexes. Abdominal reflex absent on both sides, plantar upgoing bilaterally. Sensory system, touch pain normal all over the body. He could appreciate vibration all over all the fingers, all the fingers, knee as well as over the toes. JP sensation was grossly impaired over the toe fingers and toes. So that's the story. Any questions, clarifications I can, then before going to the localization.
Sir, neck flexion, neck extension, sir.
Neck movements are restricted, not weak. Bilaterally weak, more weak on turning the head to the right side. Neck flexion is also weak.
Respiratory, sir, single breath counts.
Single breath count, I did not do. Yes, on respiratory movements are normal.
Trapezius reflex, sir.
That I did not do, trapeze. I usually am not a believer of trapezius reflex. I didn't find that very useful in our practice. Anyway, lesion is above C5.
Yes, sir. Spastic quadriparesis, sir.
Okay.
With the motor level, probably since his neck flexors are also weaker, I would like to place it in a high cord, sir, cervico-medullary junction. Probably, sir.
Because if the sternum muscles are also weak, means lesion has to be C1 to C4. It may be anywhere C3 or C4. At that level, should be affected. Because spinal axillary is coming from the anterior cells of C1 to C4. So it's clearly upper cervical cord lesion. Your said is correct. Now, but he has also got impaired joints.
Other possibility could be radicular neuropathy, sir, because of the neck muscle weakness and acute onset quadriparesis with no sensory at all.
He had sensory impairment, JP sensation, both. That is very definite. But however, he has got brisk reflexes and upgoing plantar.
That can be the day 1 and 2, it can be brisk, sir. But underlying, if it is a myelopathy,
he has got an upgoing plantar also. He has got spasticity also in the finger flexors. So
But,
undoubtedly, he has got a pyramidal lesion.
But the onset of symptoms and the presentation doesn't look like acute compressive myelopathy. No, sir.
No, nobody said compressive myelopathy. That is evolved over a period of hours. So first of all, you have to find out the site of lesion, then take the onset and everything for further etiological diagnosis. Here the localization is whether first is any weakness anywhere, first step is whether it is UMN or LMN. Here it is clearly UMN. There is no evidence of an LMN. Reflexes are not absent, there is no placidity, instead of spasticity, plantar is outgoing. So you have to always consider pyramidal lesion, bilateral pyramidal. Next
So,
is
but
where
bladder
is
is
the
not involved. No, sir. Bladder is not involved. No.
yeah, that
But
need not be all safe.
grade 0/4 with upper and lower limbs with no bladder involvement. It's a bit
Right.
of odd. No, sir.
No, right. That all depends upon to what part. See, bladder fibers are most medially situated, no? Right? And again, that point I'll come to that later. If I tell that, the answer will come. Okay. But definitely bladder, pyramidal lesion is there, no? Bladder fibers may be affected, may not be affected.
Sir,
That may be a
vibration
chronic
is-
one, no, sir. The myelopathy may be chronic one. On that, maybe he had an acute symptom, no, sir.
No, he was totally asymptomatic prior to that.
So since the patient had a neck pain prior to the
At the
event,
onset. Yeah,
dissection,
correct.
a
Correct.
dissection should be thought of, sir.
Yeah, it could be. It could be discussion producing ischemic cervical myelopathy. That's a good
Yes,
thought,
sir.
good possibility. Yes.
Mhm.
But my question is, he has got JPA sensation, upper or lower absent, without any loss of pain sensation.
So it can be localized into the cord, sir, because usually the
Yeah,
large fiber sensation, if it is predominantly the peripheral part of the nerve, vibration will be more affected. If it is the cord, the posterior tract, then joint position sense can be affected, sir. And
perfect.
this
You
involves
have got
the
yeah, that perfectly agree with you. My question,
yes,
I'll
sir.
come to that point. So he has got involved with the pyramidal tract and posterior column. Agreed. Okay.
Yes, sir. Yes, sir.
But spare in the spinothalamic tract. Pain, spinothalamic
Yes,
tract
sir.
is pain. Okay, that's a
Yes.
question here. Okay. So in
Okay,
fact,
sir.
the posterolateral syndrome.
Yes, sir.
Okay.
sir,
And
Uh,
acute presentation.
yes, sir. You are asking about the etiology, sir, or
No,
structure?
no. What we know is a site of lesion cervical cord.
Yes,
That's a
sir.
logical localization. We have both C5, maybe C3, C2. The transverse
Yes, sir.
localization means which are the tracts affected, bilateral pyramidal and bilateral posterior column. Agreed.
Yes, sir.
Right?
Yes, sir.
Right. That's
Yes,
our so we have localization is perfect. Now what is
sir,
etiology?
vibration is able to appreciate, sir.
Yes, he is able to feel vibration.
That
But as
explains, sir.
that no, that's not against. But as I don't know the name of the doctor, as she perfectly said, in cord lesion, post-column lesions, the joint sense is more affected than the vibration. In the joint sense, in the case of post-column type of sensory loss, the peripheral nerves, vibration is lost more than the joint sense.
Okay.
And that is point number one. Second point is that the vibration sense can be carried, need not always go to the posterior column, can be transmitted through the spinothalamic tract. That is where some of the syringomelia, you can have loss of pain, loss of temperature, and loss of vibration with the sparing of joint cells. So that's also possible. So these need not occur together in posterior column lesion.
Okay, sir. Thank you.
Okay. So
Sir,
that's
the
your localization.
lesion is in the cervical cord, but the onset is suggestive more of a vascular etiology.
Exactly, vascular, exactly. There is over period of it is perfectly right. Pain.
But the spinothalamic tract is paired that we are
Yeah,
bilateral.
right. Correct. That is the point I was trying to drive at. If it is a vascular, why the posterior column is affected? Spare the spinothalamic.
Yes.
Okay, that's why I brought the case. Okay, let us see. So all you say cervical cord myelopathy, most likely ischemic myelopathy, as you said. Maybe acute disc prolapse also you have to keep in mind. Some compression behind also. So what test you need?
MRI, sir.
Cervical.
MRI of the cervical spine. Okay. Next day afternoon it was done. This is the MRI cervical spine. I'll show each cut later on. This is more close-up view. This is the CVJ T2 axial, C2, C2, C3. Again C2, C3, C3, C4, C4, and C4, C4, 5, C5, C5, C6, C7, and C7. And upper cervical, upper dorsal cord. This is T1 axial. Again, no, nothing abnormal could be made out in the cord. So, what do you want now?
Still a detail cut, sir.
Detail cut is also taken, that is normal.
Contrast, sir. ASAP. Posterior spinal aneurysm.
By contrast, for?
Sir, there was some snake eye type, 2 dots were seen in the C
No,
spine.
no, it is not there. Dots I seen better, they not, for that contrast is not required. You need a good T2 film is required. Here it is not there. This is the other T2 films are already not show. It did not show any lesion inside the cord. You can take my word for it. No snake eye appearance.
Diffusion was normal, sir.
But disc is normal.
Diffusion, sir. Diffusion of cervicals.
Diffusion was not done. The cord lesions, diffusion may not pick up all that. If it is there, it is good. Therefore, you need a good MR. It was not done in this patient. But again, as previously the doctor was telling, you have to think logically. If it is ischemia producing involvement in the perimeral tract, it has affected the posterior column, sparing the spinal thalamic. Okay, now let's see so what else you need?
CSF and NCS.
Okay, CSF and NCS. But NCS by NCS, there's no nothing to such a peripheral nervous system involvement. CSF, I can agree with you. There may be some bleed or something like that, cause ischemia, duolarity, okay, that you can consider. Okay, do you want MRI brain? Pardon?
Technically, within 1 day, the reflexes are so brisk, sir. That is one
Yeah.
odd.
No, it's not odd. It's not odd. See, it all depends upon the acuteness of the involvement. If it is involving over a period of few hours, reflexes can be brisk also.
Spinal shock.
Yeah, that spinal shock, it's not a spinal shock. Spinal shock by definition is that the patient have a complete loss of motor, sensory, and autonomic function.
Yes.
Here, there is no sensory loss. Pain is preserved. Reflexes are not lost.
So I think if it is a chronic myelopathy with overadded neuropathy, some radiculopathy or something like that.
But in in fact, there is no process history. Moreover, even if you think of radical neuropathy, what is the evidence for radical? Nothing, because there is no reflexes are not lost.
Yes.
Because of the hypotonia alone may not. No, it's not hypotonic. Spasticity is there in the upper lip.
Yes.
Finger vessels is spastic.
Yes, sir.
Yeah, so it's a spastic.
So since
Anything
there is a bulbar effect or no the cranial nerve involvement, why should
No.
we for an MRI brain, sir?
Like, it's not required actually, but MRI was done anyway. Because the lesion can be above also, no? Theoretical
Yes,
possible. Yeah. So MRI was done. Let us analyze the site of situation. Yes, bilateral pyramidal weakness of both upper and lower limbs, posterior column affections, the parathalamic tract, correct? Okay. That is a posterolateral syndrome. The same discussion which we had. Now, what are the usual causes of posterolateral syndrome? Subacute commit degeneration, HIV, copper deficiency, etc. With that, how can this pick up two tracks selectively, only sparing the in between? So they usually think of a metabolic or degenerative condition like that. However, inversion is acute. So it cannot be degenerative or metabolic disease like that. Most likely ischemia itself.
It
Now,
can be
is there any-
myelitis also, no, sir? The MRI
Pardon?
can be normal initially, sir. It can also be myelitis also, no, sir? Demyelinating myelitis.
Yes, yes.
Which is myelitis, which can be normal in initial few hours.
Right, yeah, that's what they can repeat MRI after some. That's a good thing we can, you not always pick up initially. But usual situation is by the time deficit occurs, DML usually is picked up in MRI. Anyway, we can repeat MRI. Now the question is there any evidence the lesion is not in the, somebody asked me why MRI is take brain was asked for. Is there any evidence that lesion is in the cervical? Not in the cervical column. The same thing we ask you. It's an acute or subacute structural, just 1 minute, Sudhir for that. Sudhir? Hello? Yeah, yeah. Yeah, I could, no problem, absolutely no problem. Straight away I could, yeah, absolutely no problem. It went on very smoothly. I'm taking class now. Okay, thank you very much. Thank you, Sudhir. It's an acute or subacute structural lesion spinal cord is less likely because the lesion has to affect both pyramidal tract and the posterior column. It is very unlikely to involve sphenoidal tract as well as we discussed. Be it infarct, be it hematoma, be it something compression. This is little odd, no? It should spare in the tract in between. Moreover, it does not fit with the vasculature to the spinal cord arterial supply. Because sulcus commission artery supplies pyramidal tract and the spinal. Now, next question. Is there any site where both these structures can be affected in an acute lesion? You think about a site where they come close together, so it can be affected by a structural lesion, acute structural lesion.
Anterior medulla, sir.
Very good, perfect. So I come to that later. Okay, so what that is why you want an MRI to be done, on the brain to be done. Okay. So here is MRI, what is done? Flare. This is a sequence of MRI. Medulla, brainstem, midbrain, hemisphere. This is the diffusion sequence. So once again, angionormal. So what do you want to do now? When you request for MRI cervical spine, if normal, do the MRI announced. That's what usually request we goes. So what do you think now? What do you want?
Coronal cuts,
Of brain or cervical cord?
brainstem.
Medulla.
Medulla, okay. So it is in the pyramidal tract. Now let us analyze the situation once again. Point number 1, pyramidal tract at to rabo, C2, C3, that all I know. Because he had weakness of both sternemastoids. Lesions also have posterior column sensation. If it is not in the cord, where else could be? You have to necessarily think of a site where the pyramidal tract posterior column come close together. That is in the medulla. See, look at the picture now. See, this is the pyramidal tract anteriorly. This is a medial lemniscus. Okay. If these two are affected closely, you get the same thing. Spalathalamin is far lateral here. Okay, unlike in the cord. Because in the medulla, the posterior column, which is present in the posterior part of the cord, through the internal arcuate will cross and comes to the anterior part of the medulla, near the pyramidal tract. So there is a lesion here, you can affect pyramidal tract as well as posterior column, sparing the parathalamic tract. So that is the argument. So what else you want now? Thin cut of the lower medulla or upper cervical column, CV junction problem. Okay, just after crossing of the posterior column by cranial and tunicate nucleus, internal arcuate fibers. So MRI cervical medullary region is asked for specifically. So this is a diffusion film of the cervix. You can see the hyperdensity there. Again, you can get the hyperdensity. Now, if you look at the previous MRI, in fact, there is it's not very true. There's some suggestion of a hyperdensity there in the anterior part of the medulla here. But only retrospectively you can, otherwise we'll pass it off as normal. So MRI was repeated on the third day. See that diffusion resistance has increased. You can see the heart sign. The heart sign can be seen in the medulla. The both pyramidal tract is affected. See the heart sign? I'll show the picture once again. See the heart sign now very clearly. Anterior medulla and the medial meniscus. See, this is a heart sign. I think the brightness is more, that is why. Sorry. The diffusion sagittal was taken again. You can again make out the hyperdensity anterior part of the medulla there. In fact, T2 sag was repeated. That shows that in this hyperdensity extending down to the anterior part of the cervical cord here. See that area. That is anterior medulla coming to the down to the anterior territory of antispinal artery also. The upper part of cervical behind the odontoid. This is the T2 axial. You see the hyperdensity there in the anterior part here, typically here. That is upper part of the medulla. So-called heart sign. That's the upper part. That's upper medulla. Sorry. That is the pons. I'll show once again. From the upper cervical cord going up, hyperdensity anterior to the cord. Anterior cord. Now the medulla, the medullary pyramid is affected. Side also you can make it out very clearly now, second one. Now, what is the diagnosis now? Very obvious, no? This is a bilateral medial medullary syndrome. That is, both antispinal artery is supplying joint to the form antispinal artery is formed by the two branches from the vertebral artery. When that is affected, compromised, you can have involvement of both medulla. But usually what happens is that the two branches which form the antispinal artery, one may be hypoplastic. Only one may be supplying mainly to antispinal artery. So if that artery is affected, again, this upper medulla, lower medulla is affected. When the antispinal artery is formed, it comes to the anterior part of the spinal cord. The branch from the antispinal artery is affected. Only if it is one is dominant, you get anterior medulla affected. Here actually, most likely one branch may be hypoplastic. That is with the anterior medulla as well as the anterior part of the spinal cord also is affected. It is because the antispinal artery is also affected, supplying the upper part is also affected. That is, the infarct is coming down to the anterior part of the spinal cord. So, in fact, this is an uncommon combination of two major syndromes affecting bilateral medial medullary region. The associated symptoms are flaccid quadriplegia, sparing the face, hypoglycemic palsy, and respiratory failure. Sometimes, if the lesion is infarct is more, you can involve the hypoglycemic palsy can also occur. This is how this is formed, the antispinal artery, you can see here. This is areas affected to produce the medulla. Here affected to produce antispinal artery. One branch may be hypoplastic, the other may be dominant. If that is affected, entire lower medulla and the upper cervical may be affected. This is the picture only. Now here again, remember that because the leg fibers run in the ventral part of the medial meniscus, just dorsal to the pyramidal tract, sensory loss in the leg may be more severe than in the arm. Hemiparesis usually excludes the face, but facial palsy may occur in patients whose human fibers in the face swing down to the medial medulla and recur rostrally into the pons reach the seventh nerve. You understood that point? See, the fibers supplying the lower part of the face can be affected in even medullary lesion. This I had shown 2 weeks back one case. The fibers supplying the lower part of the face descend down to the medulla, the corticus, along with the cortical fibers, the anterior part of the medulla. Then cross to the opposite side and go posteriorly, ascend in the posterolateral part of the medulla and reach the inferior part of the nucleus subthinum. So if in medullary lesion also, if can have a contralateral, in a human type of facial pulse. See, you may erroneously diagnose a lesion above mid-pons, but the lesion may be in the medulla itself. Then sometimes ipsilateral element tongue weakness occurs because of paramedian, that already you know. Someday human tongue weakness also can occur because if it happens to involve, see, the upper motor fibers come cross to the opposite end of the hypoglossal nucleus. If the infarct happens to involve the upper motor neuron fibers of the tongue above the crossing to the opposite side, then you can have contralateral tongue paralysis. So you can have ipsilateral element tongue paralysis wasting when the hypoglossal nerve is affected. At least it's more rostral if the pyramidal fibers are, the cortical fibers supplying the tongue is affected before crossing. You can have a contralateral 12th also is possible. So human tongue paralysis or may occur medial syndrome because of the human fibers are affected. Isolated bilateral tongue paralysis may be the only manifestation of some medial medullary syndrome. Okay, some patients can have vertical nystagmus and other movements, etc. And game plays cruciate and all. So next question is, why is the tongue spared in our patient? In one study, only 6 out of 13 patients had hypoglossal palsy of this particular syndrome. So abscess of tongue involvement may have several reasons. The medial medullary lesion may not extend laterally to interrupt the hypoglossal nerve fibers or dorsally to involve the hypoglossal nucleus. Moreover, the hypoglossal nucleus is a long column of cells along the medulla, and release of the small portion of it may not cause a detectable exit. Okay. The characteristic brain MRI finding of heart appearance, bilateral medial medullary syndrome has been described in multiple case reports. Okay. This is from the literature, the classical hearts. It was there in our patient also, but the picture was not very good. This is from the literature. Now, another peculiarity you should remember in medial medullary syndrome that some people can have a upbeat nystagmus. Upbeat nystagmus is due to this peculiarity of upbeat nystagmus in medullary lesion is that the nystagmus will be more on looking down. Usually, classically, upbeat nystagmus is classically seen in upper midbrain lesion or in the central pontine lesion can also produce. There, the upbeat nystagmus is more on looking up. It will be less on looking down. On the contrary, if you find a medullary lesion causing upbeat nystagmus, the nystagmus amplitude is more on looking down. That's a peculiarity. Look at this patient. He had a cavernoma in the medulla with bleed. He's got upbeat nystagmus looking up. Or looking down, see the amplitude is much more on looking down. That is typical of a medullary lesion. And if you are interested, I will tell the mechanism. Otherwise, we will skip that mechanism of upbeat nystagmus.
Still the mechanism.
Okay, okay. No, in fact, for that you should know the connection between the superior semicircular canal and the inferior superior canal. So forget about that connection. Just in simple ways, you can see that the superior vestibular nucleus stimulation tends to move the eye upward. Stimulation from the superior semicircular canal goes to superior vestibular nucleus and drive the upward moving muscles. So when the output from the superior vestibular nucleus is affected, what will happen? The other muscle, the downward moving muscle may drift the eye downward. The inferior rectus and superior oblique tend to drift the eye downward. So you get a fast component forward. That is the classical explanation of an upbeat nystagmus because the stimulation from the superior vestibular nucleus which supplies the elevators of the eye are affected. So the eye tends to drift downward and fast component upward. That is a classic situation. Now, if you look very carefully, these have got various other connections also. This is the same pathway which I shown earlier, superior vestibular nucleus through the ventral tegmental tract up superior rectus. This superior vestibular nucleus is inhibited by the flocculus. So what will happen if there is a lesion in the flocculus? What happens? The inhibition is taken away. Superior rectus is acting much more. So they tend to drive the eye upward and you get a fast component down. You get a downbeat nystagmus. That is why classical localization for downbeat nystagmus is the flocculus. That is why in Arnold chain malformation also you get flocculus put in downbeat nystagmus. So that is because the inhibitory output from the flocculus is taken away from the superior nucleus because they leave the flocculus, which I tend to drift upward on this side. Now, the caudal medulla is inhibiting again the flocculus. Okay. If the lesion in the caudal medulla, what will happen? The flocculus is overacting. Inhibition. So in the overacting, what will happen? Superior nucleus is again inhibited. So what will happen? Inhibited mean the eyes tend to move downward and get upbeat nystagmus. Just the opposite of the what happened in flocculus. And so there is here what if the lesion is here, this nucleus is called the nucleus roller. If the lesion is here, what will happen? The flocculus, the inhibition is taken off. This will be overacting. The eyes tend to move upward and get a downbeat nystagmus. On the other hand, if the lesion is in the medulla, the nucleus of roller, the inhibition is taken off. The flocculus is still overacting, that is, it's normally inhibiting. So this is pathway inhibited. In the inhibited, upward movement is inhibited, height is downward, and you can upbeat nystagmus. That is the pathogenesis of upbeat nystagmus in medullary lesion, pathogenesis of downbeat nystagmus in flocculus. Is it clear to you? If you want me to explain, I can explain again.
Clear.
Okay. So any questions regarding the case?
So why was vibration impaired only on the toes and fingers, sir?
In fact, vibration is not impaired in upper and only, it is not impaired.
JPS, sir. JPS, sir.
JPS is affected both because that depends upon whether the whole medial lemniscus is affected or part is affected. Here it happens. See, if you look at the tertiary supply, the antemedial and small brainstem is supplied by paramedian vessels, short circumferential vessels, and long circumferential vessels. In medulla, the long circumferential vessel is a pica. The paramedian supply not only the pyramidal tract, it is a wedge shape. Okay, in pons, midbrain, all in wedge shape. In the pyramid, that is why in pyramid and midbrain, in fact, you get third one nucleus, which is situated more posteriorly. Similarly, depending upon if it is typical medial medullary, even hypoglossal nucleus can be affected, which is situated posteriorly. But it is sometimes it may also stop at the medial lemniscus. If you only supply the ventral part of the medial lemniscus, you get only posterior column loss in the lower limb alone. Here, it's the entire medial lemniscus is affected. That is why he has got impaired JPS in both upper and lower limb. I'll come to the picture once again. Now, this is the picture. See here, what is showing the brown is the lower limb, the pink is the upper part, upper limb. So if the lesion happens to involve this area, you get both upper and lower limb affected. Somewhere here is a hypoglossal nucleus here, in this part. If that also affected, you get bilateral tongue weakness also. Because the area of supply is like this, like a triangular supply. That is supply of paramedian territory. Okay, any questions?
Sir, why is the upbeat nystagmus more prominent on looking down in medullary?
No, that is not explained. I do not. You got a very intelligent question, but I don't know the answer. I was also wondering why should be more and looking down, and there must be some explanation. I have to look up and tell you.
Thank you, sir.
Right. Okay, shall I go to the next case?
Yes, sir.
Okay. It's a 54-year-old man. He in a history of having had traumatic subdural hematoma 5 years back and operated. He did not have any weakness at that time. Now, for the last 6 months, patient noticed difficulty in opening his hand grip on the left side, which got aggravated for the last 4 months. See, he was not maybe having mild weakness, but on the left side, maybe not be disabling, but whatever it is, now for the last 6 months, he's complaining that he can close the fingers, but he cannot open it. Repeat CT taken 4 months back showed right parietal atrophy. No sensory complaints. No complaints of the left lobe. This is a story at subdural hematoma operated. Following operation, not any weakness, that is what they are telling. Now, for the last 6 months, patient noted difficulty in opening the hand tip on the left side, which got aggravated for the last 4 months. Repeat CT taken 4 months back showed right parietal atrophy. Look at the hand in this patient. He still he's got weakness, he can flex it, but he cannot extend it. He can flex it, but difficult to open it. Okay, I'll show the video of the patient. So the examination fine. I'll come to the hand again. Analysis are all normal. He has got mild spasticity on the left upper limb. Right upper limb power was normal. Left upper limb finger flex also good power. Very good power the finger flexes. But he cannot open it. It's difficult to open the fingers. He's trying to open but not able to. The index finger is lifting up. The other fingers is unable to lift up. Thumb also is extended. Release it quickly. He could not. He's unable to release his grip.
Okay,
Then it's open. See what is happened to the thumb and index finger. The index finger is elevated, not the other fingers. That not point because already got weakness, so there is not point in doing that thing. Biceps, triceps, etc. are all normal power. No incoordination. Lower limb, nothing significant. Power was normal. Come to the reflexes, brisk on the left upper limb. Lower limb normal. Left plantar or subvoid, but most likely old impedaces. Is vibrations embedded in the left hand? Johnson's also embedded in the left upper limb. Is it correctly on the right side? Again, sit down. Mistake.
മുടക്കൊന്നും അറിയുന്നില്ല. ഓക്കെ, ഇപ്പൊ ഞാൻ അനക്കുകയാണെങ്കിൽ പറയണം, ചിലപ്പോ അനക്കത്തില്ല. ഞാൻ വിരല് പതുക്കെ അനക്കി തുടങ്ങിയാൽ അനക്കിന്ന് പറഞ്ഞേ.
You cannot have significant joint sense with the little finger and the thumb. Graphis is also affected on the left hand.
അതേമാതിരി വേറെ നമ്പർ ഞാൻ ചെയ്തു, ശ്രദ്ധിച്ചിരിക്കണേ.
You could not tell the number.
ഒരു വരണം പ്രശ്നം.
Tactile localization is impaired.
എത്ര പേരുണ്ടായിരുന്നു?
I asked him how many fingers are in between. That also he could not say.
ഓക്കെ, ഇപ്പൊ ഉണ്ടല്ലോ 11 അടിക്കാൻ 10 മിനിറ്റ് ആണ് സമയം. 10 minutes to 11.
Clock drawing he did relatively well. No problem. He said correctly. He returned correctly. So this is a construction is okay. So on examination, high malfunction scale is normal. Motor spasticity of the left upper limb. Power normal power. Severe loss of hand and finger dexterity. He could not open his fingers after closing for a long time. Sensation, impaired joint sense, position sense, tactile localization, graphis of the left hand. So question now is, what is problem with his left hand? Why is he unable to open his fingers?
Sir, finger extensors power is normal, sir.
Power is normal. When you examine an open hand like that, is normal. You can see the finger. But you close it, then you cannot open the fingers. That is his complaint also.
Any dystonia, sir? Dystonia of opening.
Okay, dystonia. Okay. Anything else? Any other possibility?
Would it be like an myotonia feature, paramyotonia like feature, sir?
Okay, myotonia is also possible, but myotonia, when a disease like this, confined
this is
only
not
to hand is
unlikely. In this
myotonia. Yeah, very unlikely, but myotonia can also behave like that. What is said is correct. Myotonia is a DD because also he can be unable to release. Then by definition, myotonia is inability to release the muscle after contraction. Persistent contraction. It's a myotonia also. Only thing is, situation is little odd for a myotonia, confined only to the left hand. He has got a severe posterior column sensory loss. Posterior column type cortical sensory loss.
Could it be due to impaired cortical sensory loss, sir? But the flexion is not involved.
Yeah, the other say no, cortical sensation means okay, it's impaired, but he can do it voluntarily, the contract the flexors, but cannot extend the flexors. Is the cortical sensitive, why that alone should be affected?
So like in thalamic hand or patients with posterior watershed infarcts usually have this hand movements which we are not able to describe. So it can be put under task or action specific dystonia, or there is.
Okay, thalamic hand is classically it's a dystonia. They keep the hand like that. That's a dystonia seen in thalamic hand. Okay, let us see. Is it first of all, is it apraxia? No, because he has got, as somebody says, myotonia can be an alien hand phenomena, minor motor perseveration. Let us see one by one. It's not a learned motor act to call it apraxia. It's only unable to move in one particular movement alone is affected. Second problem is able to relax the fingers after contraction. Minor myotonia is myotonia because it is not present all the time. Can be alien hand. It's not a purposeful act. minor motor possible, but less likely because when the hand is finally opened, only the index finger is opened, not others. This will not occur with the motor perseveration. See, if you're opening, this is able to, this will come up and thumb will also come up and it goes like this. That will not be seen in motor perseveration or anything. That's also unlikely for an alien. It's all against alien concept. So what is your diagnosis? Okay, I'll come to the diagnosis later. See, old CT taken 2000, that's 5 years back. This is the subdural hematoma he had, traumatic subdural. Then this is immediately after surgery. Then the one which is taken now, 2 months back, after the onset of this hand problem is this. But a parietal lobe atrophy on the hemisphere. So what else you need?
Anything in the thalamus, sir?
There is nothing in the thalamus, only in the cortex. The thalamus is okay. This is thalamus, it's normal.
Can you do dystonia?
Yeah, right. Could be dystonia, right? See, conduction was okay, normal. There can be dystonia. Action dystonia, the finger precipitated action forming a fist, most likely. No, because I have shown previously 2-3 cases where the patient had gross posterocordal loss, either due to cord lesion or to the cortic lesion. Hand goes into abnormal posturing and even arm levitation. Spinal cord lesion having with the sensory loss, and the arm is going on its own, going up. If you have forgotten, I can show the case later on, similar case later on tomorrow, next week. So posterocordal sensory loss can produce athetosis, dystonia, something behaving like an alien hand. It can even go upward, levitation. So this is most likely a dystonia in this patient. Now look at the video again. That will pinpoint what the abnormal movement is. He had abnormal posturing with the right thumb, and see, the thumb goes into adducted position like this. You can see the video. Again, when you open the fingers, this will come up, this will not go up. That's again tell you that it's only some of the muscles are overacting or goes into abnormal posturing. See, when the patient is asked to open his hand, only the index finger extends. See, the index finger, the others keep on flexing. See, the thumb and index finger is extending. This is the picture. And see the thumb here on the left side, it keeps adducted to the index finger. So I got to forcefully open it out. See, this is a position. He's asked to open spread out the two fingers, which he could not. So I will show that particular video one just for completion's sake. I show that particular arm movement alone, then you will understand the problem, this thing.
മതി ഇനി കൈ മടക്കി ട്രൈ പെട്ടെന്ന് വിടണം വിട്ടെ
See this, look at the hand now.
വിട്ടെ ഒന്നും മുറുക്കി പെട്ടെന്ന് വിട്
Let me put
അതേമാതിരി ഇത് പെട്ടെന്ന് മുറുക്കി പിടിച്ചോ ഇനി പെട്ടെന്ന് വിടണം വിട്ടെ 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 നോക്കട്ടെ വിട്ടെ
He's unable to open.
വിട്ടെ നോക്കട്ടെ ട്രൈ 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 ചെയ്തേ ട്രൈ ചെയ്തേ ട്രൈ ചെയ്തേ ശരി വിട്ടോ 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 ഓക്കെ നിൽക്കി നോർക്കാൻ ശ്രമിച്ചേ
Now see what is happening. See the position of the thumb goes in abnormal posture. So by definition, it's abnormal posture.
ഇങ്ങനെ
He cannot open. You have to forcefully open the thumb out.
ഇനി അടുപ്പിച്ചേ ഇനി വിട്ടെ
Again, the index finger is opening, the other finger is not opening. Other fingers are is opening, other finger is opening. So it's most likely dystonia. And what is mechanism of dystonia here? Most likely to the posterior column sensory loss. See, for any motor movement, complex coordinated motor movement occur, you should have proper sensory feedback from the periphery, moment-to-moment feedback. When that is impaired by the loss of proprioceptive sensation, the hand cannot be worked in a perfect fashion, can go into abnormal posturing. And curiously, these all develop not immediately. Even in some midbrain stroke or basal ganglia stroke, these abnormal movements develop later on because of some kind of a defective programming is occurring subsequently. That is why these patients already developed this thing. So in fact, I put on Pacitane to find out an improvement. It not show dramatic improvement. Some improvement was there. I know we do
ഇപ്പൊ നോക്കാൻ
Pacitane.
നോക്കിക്കേ മുറുക്കി പിടിച്ചേ വിടെ 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 വിടെ
It's still there, but
മടക്കി
little
കൊണ്ടുവരെ
better than before.
മടക്കി വിടെ വിടെ ഇങ്ങനെ വിടെ വിടെ വിടെ
The thumb is
വിടെ
not adducting as much as
മടക്കിക്കേ
before.
വിട്ടെ ഇതെടുത്തേ
Whether this thing did any good, I don't know. So this is the story. Okay, any questions?
So if it to be due to cortical loss, can we call it dystonia, sir?
No, so if you look at the definition, is what the abnormal posturing of the hand due to which is repetitive and patterned. The same pattern of abnormal posturing again and again. That is the same thing which is occurring here. Same pattern is adduction, is unable to close, unable to open, thumb goes into adduction. So that is repeat on itself. And often perspective flexion. Often there is also sensory stimulation, trick movement to produce the abnormal movement also. So if you look at the definition, it fits with the dystonia. And what is causing dystonia is that dystonia need not always be due to a basal ganglion involvement, can occur due to peripheral nerve involvement, can occur due to spinal cord lesion, can occur due to brainstem lesion. All can cause dystonia.
But why
Sensory
flexion is not involved, sir? Only extension is involved if to be cortical loss.
Not due to the cortical loss. What I'm telling is that he has got a loss of sensation on all the fingers. This proper feedback is required for a coordinated purposeful motor act. When that is defective for a long period of time, the hand goes into abnormal posturing. In the case of pathogenesis dystonia, this is one of the mechanisms. Improper feedback from the periphery.
Okay.
Now, I'll show one case next week.
So one doubt, sir. If it is
Yeah.
due to posterior column deficit, if the patient looks at the hand, the abnormality should get corrected. That is
No, it will not.
posterior.
No, it is not correct because here it is not, the disability is not due to the loss of posterior column. It is because the dystonia which developed later on. Okay, that's what the dystonia is abnormal movement which is developed secondary to the loss of proper feedback from the periphery. That is, a muscle goes into abnormal contractions. So such patients will not improve when looking at the hand.
Okay, sir. Then Botox will help, sir.
Botox should help.
Sir, can you call it as a false localizing sign?
It cannot call a false localizing sign. This is a non-complication.
Exact anatomy for the dystonia is not the peripheral nerve, sir. The
Not
exact
in the
anatomy.
peripheral.
Yeah.
Oh, no.
It is the basal ganglia, basically.
No.
I'll
I'll tell you. What he said is correct. I'll tell you. Now the concept are all changing. See, even peripheral dystonia can due to pure peripheral problems. Can occur due to pure parietal lobe lesions. So the pathophysiology dystonia is not what we initially thought. That a lot of, I do not know the details of pathophysiology. Like loss of inhibition, the cortical level also can produce. The feedback from the periphery loss can produce.
Sir, a patient had a problem in the cervical region, especially involved in the posterior column. And this patient had also developed pseudoathetosis in the hand.
Correct.
So we are telling that it is pseudoathetosis. We are not telling it is an athetosis proper. Why, sir?
No. It is athetosis and it is dystonia, not pseudoathetosis. Because that's what I'll show you the case next week. Say These are all terms which is not correct. Even a peripheral neuropathy or a posterior column loss can produce abnormal portion, just like mimicking. See, if you look at a next peripheral neuropathy or a cervical column degeneration producing hand, we keep it with even eyes open, abnormal hand goes into abnormal posture. Even eyes open. There will be more on closing, but when eye opening, all the cones abnormal. Just wait, next week I'll show one case. Then you will have that. Don't worry. I'll show one case.
Thank you, sir.
Okay, shall we stop?
Yes, sir.
Yes, sir.
Okay. So see you next week.
Thank you, sir. Good night, sir.
Thank you. Good night. Good night.
Thank you, sir. Good night.
Today we had a good
Good night, sir.
discussion.
Good night. Good night.
That's what we want. Okay. Good night. See you next week. Thank you. Good night. Good night.